Hey everybody, welcome back to the I Believe podcast. I'm your host, Danet Peterson, and I'm here to chat with you guys about ctDNA and just kind of getting beyond the scans. And we've got Dr. Ma joining us from University of Wisconsin. He's with the Carbone Cancer Center, and you guys might recognize him from our I Believe seminars that we've had in the last couple of years. He's been one of the medical oncologists who has participated in panels and talked about Hepzato kit, talked about just generally just about metastatic treatment. And we're so excited to have you here with us, Dr. Ma. Thanks for joining us.
Thank you, Danet, for having me join this podcast. Looking forward to talking to you all.
Yeah, of course. So, okay, I've been a uveal melanoma patient for almost 6 years, and ctDNA is something that I have kind of heard noised about for probably the last 4 or 5. And, you know, in my oncologist office, initially it was kind of like we can't really find ctDNA of uveal melanoma in the blood. It's like looking for a needle in a haystack. And now we're kind of moving more toward, okay, but there's some tests that are getting better. They're getting more precise. So if a patient with uveal melanoma, probably metastatic or potentially high risk, is hearing about ctDNA for the first time today in this episode, what's maybe one of the most valuable insights you think they should walk away with our discussion or from our discussion with?
Yeah, no, great question, Danae. I think, as you kind of mentioned, right, this type of technology, has really just sort of exploded, sort of in the last couple of years. Previously, it was something that we had more so done, in a more preclinical setting. And later we're starting to realize that, we are able to pick up, traces of DNA from your cancer in your blood. And nowadays, it's sort of reaching the opportunity for providers such as myself, oncologists, being capable of actually ordering these tests and being able to not only detect it, but also quantify, the amount of ctDNA in your blood. And so, this sort of technology has really just been exploding, not necessarily just in uveal melanoma, but across different other cancers as well. People are using them as a means to, for surveillance, to actually see if your cancer might be returning well before your scans come up. But we're also utilizing it as well for patients who are on treatment and tracking how that ctDNA level, if it's going up, if it's treatment's not working, or if the DNA level is going down, if treatment is actually working. So this sort of technology has been pretty phenomenal, has been exploding, becoming more readily available. And I think coming out of this podcast, I think what you should be aware of is these tests are available. And I would say feel free to ask your provider if this is something that they feel comfortable ordering in their practice. And if it's something that, yourself might be interested in doing.
Yeah, absolutely. So, like he said, you guys, if you're listening, please, go into this maybe with your notes ready to be taken. Drop some comments in the comments if you're watching on YouTube and you have any questions. We'll try to get those answers back in a future date. But before we dive into the ctDNA kind of test specifically, Dr. Ma, can you just tell us a little more about your practice and how often you work with patients with metastatic uveal melanoma?
Yeah, absolutely. So as Danae, as you mentioned, so I'm a medical oncologist at the University of Wisconsin Carbone Cancer Center, and the bulk of my practice is patients with melanoma and advanced skin cancer. But I would say about 15 to 20% of my patient population are patients with metastatic uveal melanoma. And so in terms of like my practice and how I've been, for example, incorporating things like ctDNA, I've been utilizing it in actually 2 different specific realms. One of which is for surveillance, and the other is actually for treatment monitoring to know if the patient's actually benefiting or responding to treatment. Now, there's a couple of caveats, typically when I say I use ctDNA in my practice, because at this point, there's still ongoing studies right now, primarily to validate the use of ctDNA in patients with advanced stage skin cancer, uveal melanoma as well, and as well as other solid cancers. And so for my practice, I would say I've had discussions with patients about incorporating ctDNA in terms of monitoring and treatment. But for the most part, for my practice, I do treat a good number of patients with uveal melanoma using a wide variety of other approved treatment options as well as clinical trials.
Yeah, absolutely. So in managing your caseload of patients who have uveal melanoma, what do you find as an oncologist makes treating metastatic uveal melanoma unique compared with cutaneous melanoma or just other skin cancers?
Yeah. So I think, when we treat patients with cutaneous melanoma, we have a wide variety of different systemic therapy options. And we've actually seen a lot of great success with those treatment options, particularly modern day immunotherapy, also known as immune checkpoint inhibitors. In fact, we've seen a good number of these patients potentially, even being cured with this therapy, which is sort of unheard of years ago, stage 4 patients with cutaneous melanoma. But the problem, particularly with uveal melanoma, is that we don't have the same sort of luxury of having the same benefit with those therapies we use for stage 4 cutaneous melanoma. And so the challenge we have right now is that there's only two FDA approved treatment options we can use for stage 4 uveal melanoma, and there are some logistical challenges with using some of those particular treatments. For example, for tebentafusp, you have to be HLA-O201 positive to be eligible for the therapy. And then for the melphalan percutaneous hepatic perfusion therapy, also known by the commercial name of Hebzotokit, these patients have to only have liver only or liver dominant disease in order to be eligible. And so, as a medical oncologist, we're sort of faced with, what type of treatment options can we use that's FDA approved, or using off-label treatment options such as modern day immunotherapy to treat these patients.
Yeah, no, for sure. It's such a tricky thing. So ctDNA, let's kind of like help people understand. If you're, if somebody's listening, they just are like, well, what is a ctDNA test? So do you want to go ahead and define what that is?
Yeah. So, the way I sort of described, ctDNA is, like every single cell in our body has, DNA, right? That's like the foundation, the building block of everything that sort of exists. That's what leads to creation of things like proteins, right? Similarly, your cancer also has its own sort of like unique DNA, right? It's a little bit distinct from your own normal healthy tissue. And so one of the things that we've sort of developed over the years is that we've started to recognize that these cancers in your body have their own sort of DNA makeup, and you can physically try to detect them specifically in your blood. Now, you might be sort of wondering, well, why ctDNA, or why DNA in general? And the way I sort of like to think about it is like DNA could be sort of seen as like a byproduct. As cells, die or turn over, they're releasing that DNA into your bloodstream. It's like a byproduct. Think of it as sort of like one of the patients who kind of describes to me, and I love it, is, think about ctDNA as cancer poop that you can sort of detect in your blood, right? And so you can actually detect it and quantify and actually measure it as well. And
I'm
so,
sorry.
so that's actually how we can actually use the test nowadays to actually detect it. So
No, that's great. I have long thought, I mean, I've never heard of that. I have kind of come to my own conclusion of the cancer noise test. That's how I describe it to my family and friends, but I like cancer poop a little better. I'm sorry.
yeah, it's a good analogy.
That's a really good analogy. But that makes a lot of sense. So when ctDNA kind of started first making its name made, I guess, in the treatment space of melanoma, of uveal melanoma, what made you curious about just incorporating the testing into your own practice?
Yeah. So, what I will say is like for years, before the availability of circulating tumor DNA, I think the biggest challenge I face is that, scans are typically what we use, to monitor and see if a patient's benefiting from treatment or if their cancer has, relapsed or recurred. And I think a lot of times the frustrating thing is that, although our scans are getting so much better over the years, CT scans, PET scans, MRIs, there's still a lot of limitations. It hasn't been, sort of the best modality to pick up things like microscopic disease, right? There's certain thresholds where you wouldn't be able to detect it on, say, a PET scan, MRI, or a CT scan. And I really sort of thought to myself, is there better or newer technology that exists where, maybe that's something that doesn't require, exposure to radiation? Is there something that maybe doesn't require something as expensive like going through a scanner or taking up much of a patient's time, in order to find out about the results? And, sort of the emergence of, circulating tumor DNA has sort of been sort of a welcoming thing in my eyes, because it's an alternative modality for us, to sort of supplement, potentially imaging to help detect cancer a lot better in the blood.
Well, and like if you think about too, like those of you guys listening, if you've ever had scans, even if you're on like a clinical trial and you have a more frequent scan like happening where they're doing an MRI like every, I don't know, like 6 to 8 weeks, I feel like is a pretty standard protocol for clinical trials at least. But even if you're having those scans, there's definitely that aspect of like, okay, you're waiting, you're trying the treatment, and then the imaging can only show the treatment response so fast. And I think that can be really kind of like an anxiety ridden period of time for patients. I don't know if you guys can relate, but I feel like that's how it's been for me. So it's kind of nice to have that kind of in between option, I suppose.
Yeah, absolutely. I mean, as I said, I think the ctDNA space has really just emerged pretty quickly. And as of right now, we're still waiting for studies to really prove, can ctDNA eventually replace imaging? I think that that might potentially be the direction we go. But, as of right now, while we're still trying to learn more and more about how ctDNA can be used, what it's able to detect, what's the sensitivity of the test,
Hmm.
right now I sort of see it as more of a complementary test in addition to imaging. But to your point, Danae, I think one of the things I really like about the ctDNA is that when tebentafusp was sort of being studied, what they really learned was that, and what we've learned, especially in the uveal melanoma community, is that maybe scans are maybe not the best test used to actually assess the benefit of treatment in patients with metastatic uveal melanoma. What we've learned is that patients can benefit from treatment despite that ugly tumor getting bigger on your scans. With tebentafusp, even though we don't see a lot of great tumor shrinkage, what we learned, particularly for tebentafusp, is that even though we extended the survival with the treatment, and that's how it got FDA approved, but what we learned is that almost 80%, if not more, actually had a circulating tumor DNA or ctDNA reduction during the course of therapy. And that might actually explain why the drug works so well, even though we don't physically see shrinkage on the actual scans.
Yeah, and I mean, you're right. Like, that can be a really kind of mind blowing thing as a patient to wrap your head around. Is like, well, you're telling me that the treatment is working, that it's helping, but the tumor was, I don't know, it got bigger because it was inflamed briefly, or it was the same size the entire time, which obviously stability is fine, but like, in the cancer world, I think there's this kind of expectation for us as patients that we would love to always just see shrinkage. And I would venture to say, as doctors, you guys would love to see that too. But that doesn't always, that's like not the cut and clear only way to show treatment works or that it's helping. Um, anyway, I
Absolutely.
love what you said though.
Yeah, absolutely. I mean, you can imagine as an oncologist, it's always disheartening when a scan comes back and, it's growing, getting much worse. But, I think ctDNA offers that opportunity for us to kind of say, maybe, we need to think about this other result, right? Maybe there's a
Yeah.
positive or a silver lining to what we're seeing so far with treatment, especially at this particular time point during
Yeah. It
therapy.
like, it offers, it just offers more information about what we're seeing. Like,
Exactly.
and when we have more information, we can ask more questions. And when we ask more questions, usually we have better medical practice. um, and I think that's always a good thing. Okay, so like we've got multiple ctDNA tests. I know I've had multiple different types over the course of the last 5, 6 years as a patient, just trying to make that attempt, right, at finding the cells, the microscopic disease before it ever showed up in scans. And, some of them were not as, they were just kind of like dismissed as, maybe that one's not precise enough. This one's not doing what we want it. But you mentioned earlier, and I know that you told me earlier that you use a lot of the Signatera test. So as a platform, why did that stand out to you as a physician when you decided to start more regularly using ctDNA with patients?
Yeah. So, Signatera really became a platform that I commonly use because, it sort of emerged initially in the colon cancer space. And, it really had sort of skyrocketed in terms of like commercial availability. And so, as somebody like myself who was really trying to look for other modalities to assess treatment benefit or to survey patients, this was really the one that just became so readily available. And so I've really just kind of incorporated this particular test into my practice. And with Signatera, I would say I've been using it now for the last several years. I have definitely found a lot of great benefit in its use for both surveillance, treatment monitoring, but there's a lot of limitations as well. And as you can imagine, the ctDNA space, it's a lot of competition right now. There's a lot of companies who are trying to develop newer technologies to use this not only for, say melanoma, but other tumor types. And there's even some platforms, ctDNA platforms, that are also just specifically for uveal melanoma. And so it's going to be exciting to see, as this technology is becoming more readily available on the commercial side, it's going to hopefully get a lot better in terms of detection and as well as for monitoring.
Yeah. Okay, so ctDNA can just be that, like, I mean, I guess for sake of like a simple explanation of how do you have a ctDNA test, it's just a blood test, right? Like they just draw your blood. Okay, so if it's just a blood test, I've kind of heard some noise about between Natera and like other oh my goodness, other ctDNA tests, that there can be like a tumor informed kind of a test. So if it's a tumor informed ctDNA test, what does that mean?
Yeah, great question. Because, how I would sort of categorize the two main ctDNA tests that are available nowadays, it's really two main ones. One of them that's what we call tumor informed, and the other is tumor agnostic. So to talk a little bit about tumor informed, which is what Signatera is, so what you're doing is you're actually building a ctDNA test that is very explicit for the cancer that you're focused on. And so what that commonly entails is that you have to submit a tumor tissue that was either biopsied or surgically removed. And what you're doing is you're actually building a personalized test for that one patient, for that specific patient, right? So what's really nice and advantageous about it is that, as you're detecting or trying to detect ctDNA in your blood, it is very specific. It's very specific for that one cancer, right? And so that particular test is really using the genomic or the DNA features of your cancer that we're attempting to monitor. Now, contrast to that is, we have the tumor agnostic, which is, you don't physically go into the patient's physical cancer to build the test. What you're sort of doing is you're sort of generalizing mutations that you would typically expect with your cancer. And so for this particular audience, right, when we're talking about uveal melanoma, some of the most common mutations we typically see, with uveal melanoma would be like BAP1 mutation, SF3B1, GNA11, GNAQ. So because if you encompass those four main mutations, you can sort of just develop a test without physically going into the patient's previous biopsy or surgery specimen. And you can just attempt to try to monitor the physical presence of that particular DNA alteration in the blood. And so there's pros and cons, as you can imagine, to both. But for the uveal melanoma space, what's really nice is that if you encompass those four mutations, I think you've captured at least 90%, if not more, of the uveal melanoma tumor's DNA that you can detect in the blood. When it comes to both in terms of sensitivity and specificity, there's probably some variability between the two. But as of right now, those are kind of the main two major platforms.
Yeah, for sure. Okay, so tumor informed versus tumor agnostic. What's your personal preference?
Yeah.
I mean, there's nothing's on the line here. You're not being like,
Yeah.
Told that you have to only represent one company, but like, what's your personal preference as an oncologist, as a researcher?
Yeah. I have to say, I kind of like the idea of both of them, to be honest,
Yeah.
right? I mean, I love tumor informed because you're personalizing, the test for the patient for that cancer, right?
Yeah, which I mean, I think that makes sense to me, like, for sure.
Absolutely.
That feels good because
Absolutely.
I like to feel important.
Absolutely. You got to be the star, right? The patients are the star of the show, right? And so when we're talking about tumor informed, I think what's really nice about it is that you're personalizing it, right? You're personalizing the approach for the cancer. And so, in my opinion, I think when you're personalizing a test, there's a very high level of specificity. So then that means, like a false positive rate is likely to be very, very low. So that if you detect it in the blood, you know for sure that you are detecting physically your cancer that's in the blood. Whereas I think for tumor agnostic, I think that the challenge particularly for that is, you're not necessarily guaranteed, to necessarily detect, the patient's DNA in your blood. Because, there might be that 10% chance where you may not actually be detecting that specific mutation that we thought of, right? For uveal melanoma, those four main ones I mentioned. So it really lacks that sort of what we call specificity, that it's not very specific, to your cancer. Now, what I love about tumor agnostic is, you can actually build the test. The test is already made, and you don't have to go back to the patient's tumor tissue. The problem with tumor-informed assays is that you have to go back to the tumor tissue. If you don't have enough tumor tissue to build the test, then you can't participate in tumor-informed ctDNA monitoring, right? So that's one of the biggest disadvantages I see, particularly for that. But there's definitely pros and cons to both of them, and I would say my familiarity has been primarily with more the tumor-informed ctDNA testing platform.
Yeah, no, that makes sense. And I want to just, for you guys listening, if you're like, well, but wait, like talk more about that. We're going to talk more about this. This is just a little bit of like a teaser, so to speak. So please come back. We're going to have our webinar. Our next webinar is going to be covering ctDNA in more depth. We're going to talk more about the data. We're going to talk about, these kinds of kind of clinical questions of like, okay, well, like I just know somebody out there is listening and you're sitting here thinking the question, well, what if I don't have biopsy material? Can I have a biopsy done? Like I have a liver tumor. Can they just biopsy that? Hold those questions. Keep them in your head. We're going to come back to those kinds of questions later. But Dr. Ma, thank you so much for like these explanations and just kind of like laying them both out there openly and honestly. I think it's really, really helpful for our patient audience. And so I kind of want to cover, in your clinical practice, what have you noticed like in how patients are kind of receiving the information? Do you feel like it's helpful you mentioned how you're kind of supplementing it with scans, right? Scans are supplemented by the ctDNA. It's not like you're excluding doing scans. So have you found that there were moments where the ctDNA test that you did helped to like clarify something that the imaging alone couldn't?
Absolutely. No, great question. I mean, I've seen a wide range of different sort of patient responses, to the test itself. And, when I sort of present the test, as something that, if a patient wants to participate in, I would say about 90% of individuals are very interested. I think, patients come into it thinking that this is sort of a new cool technology. It's a simple blood test. If I'm already as an oncologist planning to do blood tests on you, what's an extra
one
couple
more?
tube? Yeah, what's one or two more, extra tubes of blood, to kind of see, how well you're benefiting from treatment. So, one of the things I often say to patients is that you do have to come into this, with a major caveat, which is, we still need, prospective studies. We need more studies to really prove that this is something we can actually use in practice to actually tell me as an oncologist and to tell patients, is the treatment actually working and do we actually need to change treatment? But, what I would say is how I've seen the success of, ctDNA testing is that it actually has helped me clarify a lot of things on imaging. Sometimes when you get a scan and you see something like get bigger or something is like stable, like your tumor is stable or it's getting bigger, how I've sort of seen the ctDNA test is that if the ctDNA level is sort of going down, that might actually be a better indicator that the cancer is dying off, that we're not able to detect cancer poop in your blood because we just can't detect any viable tumor, right? And so that's kind of like an indicator for me. It's a way for me to give me and as well as the patient reassurance that that scan, even though it doesn't look great, we're seeing a fall in level. So it's kind of giving sort of me and the patient a level of comfort. The other thing I've also have noticed and have seen as well is sometimes these scans, you'll kind of see these like random things that kind of pop up, right, on your scan. And you're like, oh my gosh, is my cancer getting worse? Is it spreading? And in reality, that extra additional spot you see on the scan, it could potentially just be a benign finding, but the ctDNA level test can actually give you that reassurance that, if it's going down, that extra spot or two or three or whatever you see is not necessarily your cancer getting worse, right?
Yeah.
And what's really nice is that if I'm using a tumor-informed ctDNA platform, it's very specific, right? It's specific for your cancer. So, it's actually given me, to some extent, a lot of good, sort of reassurance about how patients are doing. Now, I will admit, though, one of the disadvantages, particularly with using ctDNA, is that it does come with, I think, in my opinion, a lot of anxiety, as you can imagine, right? As you're checking these ctDNA results, Danet, I'd love to hear your thoughts about it too, but, as these results come back, right, is it great to know about these results every 4 weeks, every 6 weeks? Or is it better to just kind of wait until your scans come back, right? And so as part of my practice, I offer the patients an opportunity. Do we want to check it at every blood draw, or do we want to wait until we get it alongside with your scans, right? And to some extent, these results don't oftentimes come back, in 24 hours. They sometimes
Yes.
take a week or two sometimes to come back. And so, there's a lot of worry, a lot of angst about what the results are going to show. And so, sometimes these results, come back, and sometimes they are discordant, with what we see with the scans. That can happen too. But, Danae, I'd love to kind of hear your thoughts, from a patient perspective, do you find a lot of anxiety associated with these results?
So I would say yes and no. Um, I think, and that's one of the tricky things I think in the cancer community as patients is that we kind of tend to hold space for a lot of like both things are true, and that's one of the things that I've just had to really learn to do is to hold space for the fact that yes, it can offer some level of reassurance, while at the same time sometimes it provokes a little more anxiety. Like sometimes both things can be true at the same time or at different times. Um, I appreciate at least like just about the Natera platform. Like I like that I get a text message that says like, "Hey, we've received your test. You can expect your results by this date." Like that's what I get in my portal, and so that kind of helps me like park the anxiety. Just like on a personal level, that just helps me like park it and be like, okay, well, until we hit that date, like I'm just not going to stress about it. It's fine, because the test can only come back so fast. Um,
Right.
but I will say like I wish, in retrospect, like for me as a patient, like we did ctDNA pretty regularly for a little while, and then we kind of like it just kind of got forgotten about, and it was a tumor informed test, but like we just kind of forgot to do it for probably like 4 or 5 scans, and I didn't have anything going on my scans at that point. But then later that year, or the next year, was when I had recurrent disease or new disease showing up in my liver, and we didn't have a ctDNA kind of coinciding with that, and I wish that we had. And there, for me, there was, it's like what you said. You kind of got to take this as data, and also I think from the uveal perspective, I look at this as, no different than my doctor doing research studies of my blood, just period. Like, and the only way that research gets better and more precise is if I consent to doing it. Like I guess I just see this as the kind of thing where like, okay, maybe I'm not in a clinical trial. This is one of the ways I'm participating in the ongoing research for the uveal melanoma space, because this kind of test is constantly in trial for, can we make it better? Can we get it more precise? Both for you as an individual, but also for the whole metastatic uveal melanoma community. So like, I find it fulfilling, empowering. I don't know, like it feels good as a patient to feel like I'm participating in that way. Even if sometimes it feels like, well, is this even doing anything for me? Like, I don't know. Maybe it is, maybe it isn't. I will say for me, like in my disease, I think that we saw a ctDNA increase with a much smaller presentation of metastatic disease than we expected. Like I went from having a steady 0 for almost 2+ years, like in my ctDNA, even with known uveal melanoma in my liver, like with 1 or 2 small cancer spots that, and to your point of the cancer, the cancer noise, the cancer discard, the cancer poop, um, it just meant, looking back, it's been helpful because it's kind of made more sense of that as like, okay, well, at that point, it wasn't as active. It wasn't doing a whole lot. And now, when it did get elevated, it wasn't fun, like, but it was also not crazy, crazy high. And so that, knowing what I knew about my own baseline and just having all these data points of, oh, it was at 0, but now it's at like 2 point something. It was helpful to just see that like, okay, yes, a little more noisy, it's talking a little more, but like that doesn't necessarily mean, I don't know, like going from 0 to 2 is not necessarily the same as seeing your ctDNA go from 0 to 5,000. Like that's a really scary number. Like I think that would be anxiety producing. But at the same time, if your scans show you're stable and your ctDNA shot up, I would want to know that. I would want to know, because that would be information for me as a patient and for my doctor to be like, okay, maybe we need to get on board with what's next. Like maybe we need to be prepared, and we could be wrong, right? The test could be like fine. It could turn out in a few weeks to be fine. But I think it's good information to have. I don't know if that answers your question. Sorry,
Oh,
I
it
just kind
totally
of
does.
rambled there.
No, I love that you're sharing your perspective because, I oftentimes ask a lot of my patients that, the option to say, hey, are we doing this too much? Do we want to opt out of doing this particular blood test? Because, There are times where patients just can't sleep. They're wondering what those results are. And, technically, as we're still trying to use the ctDNA test about like, how are we using this test to actually change our management? We're not quite there yet. It's still to some extent a degree of like, research, but I will admit there are so many scenarios that I could tell you, Danae, that I've actually utilized the test and I've actually, for me as a provider, to find it very helpful. So for example, just kind of like on a similar boat as you, Danae, I've had patients where, they've undergone successful treatment of their uveal melanoma in the liver, right? Whether it's a treatment with radiation, surgery, or Hepzato. And then I put them through what we call a surveillance period. I just do scans, every 2 to 3 months. And sometimes what I will typically do is like maybe I might check their ctDNA level maybe once a month, maybe every 2 months. But if at any moment I see that the ctDNA level goes from 0 to a positive value, then that might be an impetus for me to say, hey, I need to move up your scans a little bit sooner, right?
Yeah.
And if I get the scans up sooner and I happen to not see where the cancer is coming from, because, right, if you can measure ctDNA in your blood, there might be something that the cancer might be somewhere in your body, then that means I might need to use a different imaging modality. And what I have used in the past is if an MRI or a CT scan cannot detect where this melanoma DNA is coming from, I'll use a PET scan. And the PET scan has ended up for me showing that the DNA is actually coming from the bones, and that's not as easily detectable based on MRI or CT. And so, the ctDNA test has actually helped me, whether I like it or not, whether it's still research or not, it's actually told me like what I need to do to better inform, detect the cancer much sooner so that I can get them on treatment much faster as well.
Well, yeah, like, and I think it sounds kind of like okay, I got this positive result. I don't see it in the MRI on the liver. I don't see it in the CT of the lungs. Then I'm going to keep looking. Like that, to me, it's going back to what I said earlier. Like, you've got to just keep asking the questions. And that's what it provokes for you as a practice or as a practitioner, is that you get to go, okay, well, it's positive somewhere. Where? Let's see what,
Right.
what other ways can we find it? And then if you still don't find it, then now you just know, okay, we're just going to monitor you a little more closely for a little while just to be safe, right? Like, and I guess as a patient, I like that reassurance. Scans are anxiety producing enough as it is. I've talked about that a lot. There's no way to avoid it. Like, when we have imaging that comes up, whether it's every 3 months, sooner if you're on a clinical trial, there's no way to avoid it. And I think that, sitting with that anxiety, whether it's yearly or biannual or whatever frequency you as a patient have to deal with, we have to just get better at doing that, because it's a disservice to our care as patients, I think, to ignore possible information that could be helpful in determining, okay, should we do this? Should we move things up? Should we try something different? I think those are like, that's how our treatments, the treatment landscape of uveal melanoma, I think, can get better, is that, it will get more precise, and it only gets more precise if we as patients are willing to be a little bit uncomfortable.
Absolutely. No, you bring up a great point, and I love hearing sort of the patient perspective. I think it helps me and future researchers as well better understand like how can we better develop our technology so that it becomes informative and helpful for patients, right? I think the big thing I often think about as well is like, how can I make my patients live longer and have good quality of life, right? I think those are two important factors I think about as a medical oncologist. I'm a firm believer where if you can detect it earlier, you can treat earlier, and patients are more likely to have a better outcome. But what we haven't quite learned yet, especially with ctDNA testing, is, does earlier detection and intervening upon it much earlier, does that translate to better overall survival? I think that's still an area, I have to say, as an area of ongoing research is, how much does being aggressive with management early on actually translate to a much better outcome? And so again, as we're talking about research and using this particular test, I think that's something that I look very much forward to. And that's why I love it when patients are willing to participate in studies. For a rare cancer like uveal melanoma, we can only get better at treating it if patients agree and participate in studies, to be involved in it. And we're very excited to publish a lot of the literature and data on using this test for this disease.
Yeah, I know. I'm so excited. So, like we said, we've got more coming for you guys this year. Really, in the next, it's spring, guys. Like, we've got lots coming. But we've got our upcoming webinar, and we're going to have Dr. Ma back, as well as some people who are going to be representing kind of the scientific I don't know, the scientific research side of things from Natera, and we're going to, potentially bring in another doctor or two who are going to help participate in that webinar. We've got some more like personal experiences about ctDNA coming your way. And then Dr. Ma, you have a publication coming out at ASCO this summer, correct?
Yeah,
Or it's
we
been
submitted it.
submitted? Yeah.
Yeah, we've submitted a few abstracts, really highlighting the utility and use of ctDNA. And so, we'll find out hopefully in the next couple of months or so. But we're excited to kind of, publish more on this, ctDNA platform and how it could be used in practice.
Yeah, absolutely. Okay, so just to wrap up, if you're listening and you're like, okay, but what do I bring to my doctor? Like, what do I say? What would you recommend a patient bring to their own physician if they're wanting to just ask about this in their next appointment?
Yeah, I would say, if you're interested in learning more about ctDNA and, seeing if it could be somehow integrated in your care, I think it'd be good to just kind of ask your doctor, is it something that, they're familiar with? Not only are they familiar with it, but is it something that they have integrated into their practice? It does require a little bit of a workflow, especially in the clinic setting to actually get the testing set up, and organizing it, coordinating the blood test. So that's what I would encourage is, if you've heard about it, you're interested in learning more about it. Is it right for me? Do I have enough tumor tissue in order to build the test? Ask your provider and, they can always learn a little bit more about it and inform you about the options that you can do.
Yeah, absolutely. And I would also say too that like these kinds of tests also have really good patient advocate programs. I know like the Signatera test they have a patient advocacy like group where they can help you as a patient kind of like bring it to your doctor if they don't have it set up and just kind of like show them, hey, this is how we can get it integrated into your practice. I've found Signatera to be really, really pleasant to work with as a patient. From the getting the results standpoint to also just like talking with them in the back end of like even for the billing and things. At least my experience so far has been that they kind of behave a little more like Castle Biosciences, which is like at least for uveal patients, if your insurance is struggling to foot the bill or to say yeah we're going to do this, Natera has been really good about utilizing just good ways to appeal on your behalf so that this does not become something that you as the patient have to like foot the bill for. But again, we can talk more about that and kind of get into the nitty gritty of that in next episodes and in the webinar. Anyway, okay. Well, Dr. Ma, this has been so fun. I feel like the science stuff is so fun to talk about, but I feel like you do such a good job of just bringing it to the patients and also giving us some fun analogies. I would like a poop emoji. I would like that to be put up on the screen at some point. So I'm just, gonna put that out there. But this has been really great. And I really I'm with you. I look forward to seeing how the research can just continue to improve and what a gift it is that we as patients can participate to some degree.
Yeah, I'm excited about the future. And thank you for having me join this podcast.
Absolutely. Well, thanks again to you guys for listening, for subscribing if you haven't already on our YouTube channel or the podcast platform that you are choosing to listen on. Please share this. Share it with your doctor, share it with your friends, share it with your caregivers. And just a huge thanks again to our current sponsors for the podcast. We've got Delcath Systems and IDEA Biosciences. We couldn't do this without the sponsorship and just kind of the support from the back end of everything. So thank you guys for being here. Thanks for participating, and we will see you next time.